Good morning, students. In this video, you will learn about care of patient with depression. Depression is a state of mental illness characterized by deep, long-lasting feelings of sadness and despair. Depression can change an individual's thinking, feelings, and affects social behavior and sense of physical well-being. It can affect people of all ages. Women are affected twice as often as men. Lifetime prevalence for women is 26% and 12% for men. About 5 to 10% of patients with untreated, inadequately treated depression commit suicide. According to World Health Organization, major depression has become the second most prevalent cause of illness-induced disability worldwide. Suicide is a fatal outcome of depressed individuals, especially if accompanied by ongoing feelings of hopelessness, insomnia, panic disorder, or alcoholism. Those individuals are amenable to nursing interventions that can prevent suicide. The nurse needs commitment, good assessment skills, and therapeutic communication techniques to help patients learn to identify their feelings and regulate their mood. Classification of depression according to ICD-10 starts with F32, depressive episode, mild depressive episode, moderate depressive episode, severe depressive episode without psychotic symptoms, severe depressive episode with psychotic symptoms, other depressive episodes, atypical depression, depressive episode unspecified, recurrent depressive disorder. Etiology of depression, it is discussed under biopsychosocial model. Biological causes, genetic vulnerability. It runs in families. It often occurs with first degree relatives, 70% chance with twins. Neurochemistry, neurotransmitters in the brain, when they are working normally, they regulate biological process and also helps to keep up with normal mood and emotions. But when there is imbalance, it can affect feelings of happiness and pleasure, which can be a cause for depression. Immune stress response. Little stress is good for an individual, which makes him alert, motivated, and primed to respond to dangers. But when there is sustained or chronic stress in particular, it leads to elevated hormones such as cortisol, the stress hormone, and reduced serotonin and other neurotransmitters in the brain, including dopamine, which has been linked to depression. Physical health, when it is poor and deteriorating. Metabolic disorders, comorbidity, to name some: persons with Cushing's disease and Huntington's, cardiovascular disorders, diabetes mellitus, multiple sclerosis, and end stage of cancer. Viral infections like HIV, hepatitis could also lead to depression. And drug effects, drugs such as beta blockers, corticosteroids, anticonvulsants, and benzodiazepines, proton pump inhibitors, H2 blockers, and diet and lifestyle, like lifestyle, sedentary lifestyle, when there is no exercise, diet, when the person is not following well-balanced diet, and response to reward and emotions, when there is dopamine imbalance, it leads to lower level of activity in the reward circuit of the brain. And psychological self-esteem, when the self-esteem is low due to unhappy childhood, chronic low self-esteem, or due to poor academic performance. Attitude and belief, when there is negative attitude, it depletes the brain chemicals, and belief system and religious belief practices also. And perception, when the person faces stressful life events, if he has taken his perception is distorted, it could lead to depression. And coping mechanism, if he is adopting maladaptive coping mechanisms like going into alcoholism, drugs, or substance, that could lead to temperament, when the person is not able to control his temper, like anger. Anger is when it is not controlled, serotonin, norepinephrine, dopamine, GABA gets affected. And social skills, the person when he is not able to use or practice good social skills, like accepting other person, respecting other person, showing empathy towards others, cooperating with others, and also understanding the feelings of others. Interpersonal relationships, when there is relationship breakdown, being in an abusive relationship, trauma and grief, when there is loss, breakup of relations, and social environmental peer group, when the friends around the person, when they are always with negative emotions, that could be the reason. And the school environment, when the student has cognitive distortion, say for example a student scored low grade in exam, he thinks all the time that he didn't study, or he blames the teacher saying teacher was unfair. And work not satisfied, being bullied at work or intimidated at workplace. And socioeconomic status, they say low socioeconomic status, like related to education, occupation, income, uh, it has been found to be associated with higher prevalence of depression. And family circumstances, like experiencing prolonged financial hardships, continuous stressful life events. And culture, when the culture is not comfortable in reporting even symptoms of early mental illness. So these are all the causes for depression. Psychopathology. When there is acute or chronic stress, there is defect in the serotonergic, noradrenergic, and dopaminergic function, and there is decreased BDNF, the brain-derived neurotrophic factor, the main function of which is to promote the development and stability of neuronal connection, and there is neurotransmission imbalance, there is increased cortisol level. When there is stress, it activates the HPA axis, the hypothalamic pituitary adrenal axis, and so it leads to HPA dysregulation, where there is increased adrenal cortisol production, and it accounts for the alteration in the immune system. There is increased pro-inflammatory cytokines, and this also one of the reason for dysregulation of HPA. And there is hippocampal atrophy. The hippocampus loses its volume, can shrink up to 20%, and there is prefrontal cortex hypoactivity, and so decreased number of cells. And limbic hyperactivity, and you know the function of limbic system, it involves in the behavioral emotional responses, memory, regulation of autonomic endocrine function in response to emotional stimuli, and the patient experiences an array of negative symptoms of depression. What are the clinical features? Depressive mood. The patient is sad, both pervasive and persistent sadness, spontaneous crying, tearful, irritable, and there is anhedonia, loss of interest in things which were enjoyed by the patient previously. Example, gardening. You used to once enjoy and do gardening, but now you may do it just for the sake of doing it. Depressive cognition. It affects his thought process. He feels helpless, hopeless about getting better, about his future, attaining hopes and dreams, and he has worthless thoughts and decreased concentration, and he has indecisiveness, unable to decide even for a simple matter, both at home and at workplace, and he feels guilty, he blames himself, and he is into substance or alcohol. Suicidal thoughts. He has feelings that life is not enjoyable, loses hope or meaning in life, starts believing that the world will be a better place without him. It leads to suicidal ideation, and he has a plan on suicide. And it leads to alteration in psychomotor activities. On the whole, the psychomotor activity is retarded. Speech becomes less, monosyllabic answering, delay in responding, voice becomes monotonous, and the action becomes, even his walking becomes very slow. In elderly persons, you would see they are anxious, irritable, restless. And psychotic features, there are delusions and hallucinations also seen sometimes. Delusions usually focus on depressive themes. Nihilistic delusion, delusion of guilt, delusion of poverty, and the somatic symptoms appear. there is disturbances in sleep. He has insomnia. He is not able to sleep, or he sleeps a lot and he finds hard to get out of the bed in the morning. And a person who was never a napper, now all of a sudden he needs nap every day. And then about his appetite. There are changes in appetite, either increased appetite or decreased appetite. Severely reduces food intake or overeats to the extreme. He feels tired, fatigue without reason, and there is history of decreased libido. And you can see here the picture, the patient looks very depressed. You can appreciate with what we have discussed just now. And yes, you can see what he has in front. Maybe he has a suicidal thought and a plan as how to accomplish the suicide plan. Diagnosis of depression is made when there are 5 or more symptoms lasting for at least 2 weeks. Psychological tests are administered to screen and assess the severity of depression. Some of the instruments used are Beck Depression Inventory, Hamilton Depression Rating Scale, Zung Self-Rated Depression Scale, and Geriatric Depression Scale. Dexamethasone suppression test showing failure to suppress cortisol secretions in depressed patients. Toxicology screening suggesting drug-induced depression. Treatment modalities, pharmacotherapy, antidepressants are given, tetracyclic antidepressants, selective serotonin reuptake inhibitors, newer antidepressants are given, and sometimes monoamino oxidase inhibitors are also given. Physical therapy, electroconvulsive therapy is given with patients who have suicidal ideation, also with psychotic symptoms. When they are resistant to drug therapy, that is the time also ECT is preferred. First, 3 treatment on alternative day is given and then twice a week, usually 6 to 12 depending upon the patient response. Light therapy is given. Psychosocial treatment, psychotherapy is given. Cognitive therapy, cognitive behavioral therapy, it is mainly given to modify patients' faulty ways of thinking about life situations. Supportive psychotherapy is given. Group therapy, family therapy helps a lot. Behavior therapy like a social skill training, problem solving skills. The warning signs of suicide, they are suicidal threat, writing farewell letters, giving away treasured articles, making a will, closing bank accounts, appearing peaceful and happy after a period of depression, refusing to eat or drink. Suicide risk factors, it is listed using mnemonic SAD persons. Sex, male, age younger than 19, older than 45 years, history of depression, previous history of suicide attempts, excessive use of alcohol or substances, rational thinking lost, reality thinking, separated or single, organized plan is there, no social support, and sickness, the comorbidity, chronic illness. We'll move on with nursing management. You'll have to follow the steps in nursing process. The first step, assessment. You'll have to have both subjective data and objective data. Diagnosis. The nursing diagnosis have to be stated, which includes the patient's problems or needs, the etiological factors, and the defining characteristics or the signs and symptoms. And plan, you'll have to set goals and then plan nursing care. And implementation, you'll have to perform the nursing care what you have planned. And evaluation, determine if goals met and the outcomes achieved. There are some possible nursing diagnoses. I have listed it down. Risk for suicide, impaired social interaction, ineffective coping, self-care deficit, disturbed sleep pattern, chronic low self-esteem, dysfunctional grieving, powerlessness, disturbed thought process, risk for non-compliance of drug regime. Now, having listed down some of the nursing diagnoses, now let's discuss few of the nursing diagnoses. The first one, risk for suicide. So I'm going to complete it with a 3-component. So it can be risk for suicide related to negative cognition as evidenced by patient verbalizes suicidal ideation. The assessment, subjective data could be, I don't want to live anymore. Objective data, patient looks tearful or impaired grooming, he displays sudden mood elevation. Nursing intervention, assess patient's risk for suicide through careful observation. The rationale behind helps to identify the patient at risk for suicide. It is a baseline data which enable the nurse to plan nursing care. Careful observation. Observation, if it is 1:1, it is very good. If it is not possible, place the patient near to the nurse's station so that the nurse can have constant observation on the patient. And she has to think about the risk factors for suicide at this point, like the very sex of the patient and the age of the patient, the symptoms of depression, how is it? Is it very severe? And is there any previous suicidal attempt? If so, what method the patient has followed? And does he have social support? Is he a separated person, single person? Does he have an organized plan with him? And is there any comorbidity? So all that she has to keep in her mind and then observe the patient. Observe the patient is all his move, his talking, everything. She has to be very careful in her observation because when she has a careful observation, she can very well pick up the risk factors for suicide. Remove all their belongings. Check the patient's room for potential objects. Every belonging, any belonging can become a potential weapon for the patient and also the other potential objects. And the rationale is nurse's first priority is to provide patient safety. Demonstrate a calm, empathetic, confident attitude. What is the rationale? It reassures the patient. It enhances trust with the nurse. So you're not going to be rude. You're not going to be, showing a attitude that it is patient is not important and things like that. Whereas when you're calm, empathetic, show a confident attitude, already there is a building of trust. The patient builds trust on you. So for the next plan, it is easy for you to carry out with the patient. Demonstrate, then show a non-judgmental attitude towards the patient. The rationale is it will enhance further disclosure of suicidal thoughts and prevent thoughts of humiliation. So that much it helps the patient. Observe patient for behaviors that are precursors to suicide. What is the rationale? Is a strong indication of patient's suicidal ideation and helps to prevent patient from acting on suicidal thoughts and feelings. The precursors to suicide could be the warning signs of suicide, what you have just now seen. It's a suicidal threat or writing farewell letters or making a will, closing bank accounts, not eating. Those things you have to keep in your mind and observe. Develop a comprehensive treatment plan. The suicide precautions, psychosocial therapies, medication, continuous assessment. Like suicide precaution, like take all the suicidal threat into consideration. Do not ignore them or attempts. All that, take it seriously and notify the doctors and search for potential things which can be used to commit suicide, like drugs, alcohols, razor blades, knives, and glass bottles, straps, clothing like belts, neckties, dupattas, and do not allow the patient to bolt his room from inside. And sometimes these days the patients are put in a room where there is no bolt from inside. Someone must accompany the patient when he goes to the restrooms, and constant observation, and especially during morning hours. So you must be very careful. And psychosocial therapists, during psychosocial therapies, again, you have to be with the patient, constantly encourage him and to see how patient is, enabled. Is he able to talk to the next person? Is he able to, little bit socialize? Uh, how is his thought? And medication, when he's given antidepressant drugs, is he able to take? When he is taking, what are the side effects he is having? And how is his, reaction to the medication? Is he tolerating? All those things. What is his thought about taking medication? Those things, and continuous assessment. These are all the things you have to plan and encourage the patient and be with the patient and enable him to carry on, because it is the combination. Only one thing is not going to make the patient come out of his present problem. It is the holistic care. So you have to take care of all the biological aspects, psychological aspect, and social aspect, and spiritual aspects, everything together. Have the patient sign a suicide contract. So when the patient has signed is writing saying that I would not commit suicide, and put his sign, you're confident that patient is not going to commit suicide to some extent. Inform and educate patient about benefits of ECT. In case if the patient is going to go, you have to talk about ECT. And as you have already learned, the pre and during and after procedure care for ECT, as a nurse you have to give to the patient. Evaluation. Patient expresses desire to live and lists reasons for wanting to live. Another one could be patient verbalizes absence of suicidal ideation. Nursing diagnosis 2, impaired social interaction related to hopelessness as evidenced by patient remains in room most of the day. Assessment. Subjective, don't bother me, I want to be alone. Objective, sits head down, avoids eye contact, restless, slumped posture. The nursing interventions continue to engage the patient in interactions. The rationale, it necessitates acceptance and persistence. Second, actively listen, observe, and respond to patient's verbal and non-verbal expressions. The rational, patient knows they are worthwhile and respected. Remain with the patient even if he doesn't engage in conversations. Offer brief, accepting comments. The rationale, it offers comfort and security and increases self-worth of the patient. And use a matter-of-fact approach when offering simple choices. The rationale is avoids threatening patient with expectations they cannot meet. I'll give you an example. A patient is found to be missing his breakfast almost every day. When you have to use a non-threatening approach, you would talk to the patient this way. Good morning, so-and-so. It is 8:30 in the morning. After 9 o'clock, they will not serve the breakfast in the dining room since they'll have to start preparing for the lunch. This is the non-threatening. But the threatening way, it is 8:30. You should be up and dressed up by now. Everybody is waiting for you. This is not the right approach. Encourage the patient to ask for assistance when necessary. The rationale helps him to understand that he must interact with the nurse and other staff to have his needs met. Nursing interventions. Gradually engage the patient in interactions with other patients, beginning with one-to-one context, the person who is next to his bed, progressing towards informal gatherings, and eventually participating in structured group activities with occupational therapy first and then recreational therapy. The rationale, patient experience success when social interactions are pursued in relation to their level of tolerance. And second, encourage visits with supportive significant persons. Allow visitors The rational social contact reinforces rewarding supportive relationships. Third, make available those activities that the patient finds rewarding and satisfying. The rational activities that interest the patient are more appropriate to provide enjoyment, which acts as a catalyst for future social interactions. And encourage to set specific times for interactions with staff. The rational, it helps the patient to accomplish positive self-generated interactions. Emphasize importance of group involvement such as psychosocial therapies during outings and group activities. The rational, it helps the patient gain support from others, learn social skills, and see that the patient's problems and concerns are similar to those of others. Continue to support and monitor. This promotes the patient's self-confidence and hope for the future. Evaluation demonstrates comforts and enjoyment during interactions, or it could be participates actively in all milieu and group activities, or verbalizes satisfaction with social interactions. Nursing diagnosis 3. Ineffective coping related to history of multiple stressors as evidenced by expresses inability to cope. Assessment subjective data, I can't do my responsibilities at home. Objective data throws anger outbursts. Nursing interventions focus on strength rather than the weakness. The rational, the patient becomes aware of positive qualities and capabilities that have helped him in the past. And second one, identify individuals and support system. Like you can say to the patient, I notice you seem to be more relaxed whenever your brother visits you. The rational, the patient becomes more aware of the positive effect of supportive individuals in his life. Assist in learning strategies that move towards positive thinking, such as guided imagery or cognitive behavior techniques. The rational therapeutic modalities help replace irrational, self-deprecating thoughts and help to prioritize problems. This rational behind it helps to reduce its overwhelming effects and break them into more manageable increments. And then praise the patient or appreciate the patient for adaptive coping. And the rationalist encourages his continuance through positive reinforcement and teach basic assertive skills such as to communicate his needs and express both positive and negative feelings in an open, honest, direct and appropriate manner. And the rational, the use of healthy assertiveness assists the patient in having needs met and coping with demands of the environment and building confidence, and encouraged to describe his role, performance, and the satisfaction it brings to the patient and the significant others. The rational promotes more functional role adaptation. Encouraged to discuss feelings generated by ineffective coping like frustration, anger. Like you can say to the patient, it's okay to talk about your feelings. It helps you to work through your problems. So the rational helps patient to externalize emotions that may be source of depression and involve family members cope with the client's troubling behavior. And the rational behind it promotes to manage family and client interaction and continue to support the patient. It can prevent harm, injury, or death. Evaluation demonstrates effective coping strategies. Nursing diagnosis 4. Self-care deficit related to apathy as evidenced by displays inadequate personal hygiene. Assessment, subjective assessment, verbalizes feelings for no interest in bathing. Objective, patient has unshaven facial hair if he's a male, wearing soiled clothes, foul smell from body and mouth odor. Nursing interventions assess which self-care deficit interferes with patient's function. This enables to determine the client's strengths as well as areas that require assistance. assist with personal hygiene such as dressing, grooming until he can function independently. The rationale, it helps to preserve patient's dignity and self-esteem, reduce environmental stimuli such as excess noise, lights, bright colors during self-care activity time. The rationale, it reduces anxiety and allows better concentration on the task. Make necessary clothes available. Say for example, patient is going for a bath, give only one set of dress. Rationale, it minimizes confusion and simplifies the selection process. And establish routine schedule for self-care, like for bath, brush teeth once daily, comb hair every morning, wash clothes twice a week. Rational, routine, structure organizes the client's chaotic world and promotes success. Initiate grooming and hygiene task when the patient is best able to accomplish. Depressed patients have more energy and brighter affect later in the day. Provide privacy during self-care with safety precautions. Helps to preserve the patient's dignity. Ensure patient is clean and well groomed. The rational, neat appearance prevents embarrassment and emotional and physical trauma that result from being an object of ridicule. Praise patient for attempts at self-care and for successfully completing the task. Positive reinforcement increases feelings of self-worth and promotes continuity of functional behaviors. Continue to support and monitor the patient, which will encourage the patient to maintain self-care routines even at home. Evaluation. Patient consistently performs self-care activities. Psychoeducation on early symptoms of depression, warning signs and risk factors of suicide, side effects of medications, and on self-care, which includes importance of regular exercise, healthy regular diet, mainly diet rich in protein, selenium, vitamin A, B, C, and D, omega-3 fatty acids, and antioxidants, stress management strategies, sleep hygiene, avoidance of substance use, and need for social network of family, friends, and community, and importance of drug compliance and regular follow-up. Thank you.